A very good evening to everybody, and I hope all of you are doing well, safe, or even if you had got the COVID, you have recovered. Okay, let's pray for virus-free, problem-free environment. As we today get into our Lymphoma Forum, thanks to Kavina Creation to be our digital partner. Thanks to the foundation who brought all of us together, and all the most thanks to CIPLA for giving us this platform where we can discuss about the lymphoma today. So we have eminent speakers, panelists, chairpersons, and all of us over here to discuss. So I'll just take 1 minute as an introductory process. It's just to tell you, yes, lymphoma is one of the cancers. I think it is curable, and I feel happy when, okay, compared to any other solid tumors, we get a hematological malignancies, the cure rates are high, provided we use the right treatment and the right way in a specialized centers. That's why we have all experts today in the forum. And few things, if you see the ESMO guidelines, and I've modified few versions of the ASCO guidelines, which guides us somehow to the how to manage this lymphoma during the COVID pandemic. And there's a special issue for second wave. And it is worth mentioning in a forum tonight is how you just alter your treatment depending upon the viral load and that what is in the present situation. So yes, be careful, prioritize your lymphoma cases. If it is indolent, yes, wait and watch can be a policy. Radiation can be provided, the exposure is not so much. Chemotherapeutic agents, try to see the high dose is difficult because supportive care becomes an issue. Less of myelosuppressive agents during this pandemic area where it might exaggerate the COVID and progresses over from a mild, moderate to a severe form. Also, we bring into discussions of how to continue the standard of care for all the lymphomas and on time, particularly those we are thinking it's our curative option. So this puts up in a lot of dilemma. Many of us are not able to follow the standard of care, and there are many drugs around. Okay, and like today we for one of our newly diagnosed non-Hodgkin's lymphoma, it was an urinary bladder with extensive mets dissemination. He was 37, came with obstructive uropathy and COVID positive. So we have admitted, and it's mild COVID. Actually, again, debate whether to start the steroids or not, because now we know in mild you should not start the steroid, but then obstructive uropathy, renal failure. Today we also started the Roche cocktail because he is a classic example of a person to fit into with a high risk on cancer treatment, renal failure, and mild disease, and within 7 days. Today we gave the Roche cocktail to him, and then planning for subsequent lymphoma treatment once he's little out of the COVID. So with this note, I just leave it to all our speakers and panelists out here. And the first talk is B-cell lymphoma, diagnosis and classification. I invite Dr. Stalin Bala to take it forward. Dr. Stalin Bala, please.
Good evening, madam.
Yes, thank you. Take it. You can share your slides, please.
Sir, are you facing any difficulty?
No. I'm sure. Are my slides visible?
Yes, sir.
Yeah. Good evening, everyone. Over the next 10 to 15 minutes, I'll be taking you through what are the important aspects of the diagnosis and classification, how the classification of the B-cell lymphomas has emerged over a period of time, and what are the important aspects in the diagnosis of B-cell lymphomas. We all know that there are more than 90%, 90 subtypes of lymphomas, and the prevalence is approximately 5 per 1 lakh in India, and they account for around 3 to 5% of all cancers in India. And we all know that the lymphomas are highly curable malignancies, and the cure rates approximately 80 to 90% in lymphomas. And we, from the ages, we know that the lymphoma is broadly classified into Hodgkin and non-Hodgkin lymphoma. And in the non-Hodgkin lymphoma, there is the classification that immature, that is the lymphoblastic variants, and the mature lymphomas. And in this session, we will be seeing majority on the mature B-cell lymphomas. And this is the broad classification how we differentiate between the non-Hodgkin and Hodgkin. And non-Hodgkin lymphoma is predominantly a disease of elderly, and it is the most common lymphoma, and it can arise anywhere in the body, and the occurrence is unpredictable, and the prognosis and wise it is not as curable as Hodgkin lymphoma, because we have a very good prognosis and high cure rates in Hodgkin compared to the non-Hodgkin lymphoma, and non-Hodgkin lymphoma is challenging to treat compared to the Hodgkin lymphoma. So these are the common B-cell lymphomas: the diffuse large B-cell lymphoma, follicular, mantle, and marginal zone lymphoma, and the small cell small lymphocytic lymphoma. So these are the various techniques how we diagnose lymphoma, right from the histology to the immunohistochemistry, and the molecular techniques like the FISH, the sequencing techniques helps us in identifying the cell of origin, and also the FISH techniques helps us to identify the subtype of lymphoma with accuracy. So morphology, we all know that the key in the diagnosis of lymphoma and the characteristic feature in the morphology is the diffuse effacement of the architecture of the lymph node, where in DLB cell we see sheets of the large atypical lymphoid cells, and in follicular lymphoma we'll see the follicular pattern with centrocytes and centroblasts, and these two are the most common B-cell lymphomas we see routinely in our clinic. This is the classical DLBCL, so where we see the centroblasts with peripheral nucleoli and minority of and in the majority of the portion, in the minority we see immunoblasts, and there are various subtypes of the DLBCL, morphologically the centroblastic variant and the immunoblastic variant, and rarely the anaplastic variant. This is the follicular lymphoma. On the morphology, we see the follicular pattern, and based upon the presence of number of centroblasts, we divide the follicular lymphoma into three grades: the grade 1, grade 2, grade 3, where the grade 3 it typically behaves like a DLBCL. And the mantle cell lymphoma, this is not as common as the DLB cell follicular lymphoma, and there are various subtypes in the morphology like nodular type, blastoid variant, and these are the small to medium lymphoid cells with irregular nuclear configuration. So these are the other rare subtypes: the small lymphocytic lymphoma and the hairy cell leukemia, and the nodal marginal zone lymphoma. These are not that quite common compared to the DLB cell and follicular lymphoma. And in the next few minutes, I will be taking through what are the important aspects in the DLB cell which are important in the clinic. And although we see the morphology of lymphoma, the most important to accurately confirm the lymphoma is the immunohistochemistry. There are various immunohistochemistry markers which are specific to the lymphoma, so that we can diagnose the lymphoma with precision. So the common immunohistochemistry markers are the B-cell markers like CD19 and 20 and CD17, and whereas the markers which helps to differentiate in the low-grade lymphoma are the CD5, 10, and 23. So this is the classical immunohistochemistry pattern of DLBCL, where the DLBCL cells generally express the pan-C B-cell antigens as well as the common leukocyte antigen, the CD45, and expression of CD30 can be seen in the anaplastic variant of the DLBCL, which is seen in the 25%, approximately 20 to 25%, and associated with more favorable disease. CD5 expression is uncommon in DLBCL, and the three characteristic markers which are needed to identify the DLBCL are the BCL2 staining, BCL6, and the Ka67. We all know that DLBCL is aggressive lymphoma, and the Ka67 is more than 40% always, and it may be occasionally more than 90% in few cases. So a majority of the cases, that is more than 70 to 80% of the cases, express the BCL6 staining, but the expression of the BCL2 in IHC is widely varied according to various publications. It ranges from 25 to 80%. So this is regarding the diagnosing the B-cell lymphoma, the DLBCL, seeing the morphology, confirming it with IHC with the Ka67, BCL2, BCL6, and CD20. But over the past 5 years, there is a lot of changes in the DLBCL, how to identify it, and is it all the DLBCLs behave as in the same pattern. And over the clinic and over the various studies, we have seen that all the DLB cells doesn't behave similarly, and 30% of the patient relapse or doesn't respond to the traditional R-CHOP therapy at all. So this led to the digging the more into the molecular changes and identifying the various pathways in the DLBCL. The most important of this is the cell of origin, that is the identification of which origin of the cell of DLBCL. That is that there are based upon the cell of origin, the DLBCLs are divided into the GCB, the germinal center B cell DLBCL or the activated B cell DLBCL. So the morphologically, the immunohistochemistry wise, they are different, and the prognosis wise and the behavior wise also they are different. So the first algorithm that developed was the Hans algorithm, where the CD10, BCL6 and MUM1 were used for classification, and it has shown that the GCB subtype is comparatively better compared to the non-GCB, and the patients with non-GCB immunophenotype will behave in very aggressively and has a very poor prognosis. Later on, refining the Hans algorithm, many algorithms were proposed like Choi algorithm, Tallinn, and Notkunam, where the different immunohistochemistry markers were identified, and uh, uh, the standard way to identify the cell of origin is gene expression profiling, but it is not available in majority of centers. So these algorithms of IHC were compared with the gene expression profiling and has shown the concordance rate of approximately 80 to 90% and can be widely used in our routine clinics so that we can identify the cell of origin with precision. So, and in the 2016 WHO update, it is proposed that it is acceptable to investigate the cell of origin based upon the IHC algorithms. What I have told, the CD10, BCL6, GSET1, LMO2 are important in GCB subtype, and MUM1, FOXP1, and CD138 immunohistochemistry markers are important to identify the ABC subtype of DLBCL. So apart from the cell of origin, what are the other factors which are important to prognosticate and which are important in diagnosis in DLBCL, or the identification of the MIC, either by IHC wise or by the FISH. So when to test for a MIC in DLBCL is all B-cell lymphoma unclassified morphology, and those who have a blastoid morphology, and those who have a immunohistochemistry wise, so if MIC expression is more than 40%, they need to be mandatorily test for the rearrangement with a FISH break apart probe. So we need to test for the MIC first, followed by BCL2 and BCL6. So various studies have shown that the MIC rearrangement can be seen in approximately 10 to 11% of the DLBCLs, and if they have a concomitant BCL2 and or BCL6, they can be classified into a double hit or a triple hit type. So apart from the MIC rearrangement, MIC expression alone can be seen in approximately 40 to 50% of cases of DLBCL, but majority of them doesn't have a FISH rearrangement, and the FISH rearrangement is seen only in 5 to 10% of the cases. And apart from the published studies, we know that the double expressor or double hit lymphomas, that is the co-expression of MIC and BCL2 or BCL6 by IHC, or MIC and BCL2 BCL6 rearrangement by FISH, they called as double hit, either a double expressor or double hit, they tend to behave aggressively. And among these double expressor and double hit, we know that the double hit tend to do extremely poorly compared to the traditional DLBCLs without any MIC and BCL2 rearrangements. And we know from the published studies, we know that the double expression of BCL2 is more frequently observed in the ABC subtype, whereas the double hit thing is more common in the GCB subtype. So now, apart from the cell of origin, we do have two other subsets, that is the double expressor lymphomas and the double hit lymphomas. And these double expressor are by the IHC, that is the MIC expression should be more than 40% and the BCL2 expression should be more than 70%. And these are most common in the ABC. They have an inferior outcome, but not as poor as the double hit lymphoma. Double hit lymphoma, the incidence ranges from 5 to 10%, where we identify the MIC and BCL2 or BCL translocation by FISH, and they are more common in the GCB subtype of DLBCLs, and they have a very poor outcome with the standard R-CHOP therapy, and they need a more intensive therapies rather than a standard R-CHOP alone. So to conclude, how the double hit lymphomas are the 1/3 of the DLBCLs are, they have a BCL2 and MIC expression by IHC, and the most of them are ABC subtype, and double hit lymphomas are most often GCB subtype. So apart from the aggressive lymphomas, the DLBCL, other aggressive lymphomas which are close to DLBCL are the Burkitt lymphoma and BCL lymphoma unclassified. And based upon the IHC pattern, we can differentiate the Burkitt from the DLBCL. The Burkitt lymphoma is classically a CD10 positive and a BCL2 negative neoplasm, and MIC rearrangement is often present in 98 to 99% of the cases of Burkitt lymphoma, and the Ka67 almost touches 100%. Whereas the BCL2 expression is variable in GCB type of DLBCL, and the MYC rearrangement is seen in only 5 to 10% of cases of DLBCL. Coming to the other B-cell lymphomas, the most other common subtype of B-cell lymphoma is the follicular lymphoma. We know that based upon the morphology of follicular pattern and the presence of centrocytes and centroblasts, we identify the follicular lymphoma, and the characteristic translocation we see in follicular lymphoma is 1418. If we demonstrate it by FISH, we can confirm the diagnosis of follicular lymphoma. And in the recent WHO, there are various other entities which are proposed, like follicular lymphoma with blastoid morphology and the pediatric type. And these are the cases which doesn't fit well into the classical definitions, and they doesn't classically behave like the follicular lymphoma. And we all know that the follicular lymphoma grade 3 has slightly behaves like DLBCL, and it has a low frequency of 1418 translocation. And the other less common B-cell lymphomas are the mantle cell lymphoma and marginal zone lymphoma. And we know that the characteristic translocation associated with the mantle cell lymphoma is 1114, which helps in diagnosing the mantle cell lymphoma, and the surrogate for IHC marker is the expression of the cyclin D1. So the mantle cell lymphoma expresses the pan B-cell markers along with the CD5, which is classical in mantle cell lymphoma. And to differentiate it from the CLL, CD23 can be done, which is positive in CLL and which is negative in mantle cell lymphoma. So rarely in cases where in 10% of cases where the cyclin D1 is negative, SOX11 can help in the diagnosis of mantle cell lymphoma. So this is the proposed molecular pathogenesis, how the cyclin D1 and the SOX11 drives the pathogenesis of mantle cell lymphoma. So from NAB cell, the institutive mantle cell neoplasia starts, where the mutation of the IgG and the expression of the SOX11 drives the pathogenesis of mantle cell lymphoma, where unmutated and SOX11 positive B cell will become a mantle cell lymphoma, the classical, and upon acquisition of TP53 becomes a blastoid or pleomorphic mantle cell lymphoma. Whereas hypermutated and SOX11 and negative B cell lymphoma becomes a leukemic non-nodal mantle cell lymphoma. So other rarer subtype of B cell lymphoma is the marginal zone, where three subtypes are there. The nodal marginal zone, extranodal, which is more common. Gastric maltoma is the most common of the marginal zone lymphomas, and the splenic marginal zone lymphoma. So we know that in the gastric maltoma, the characteristic translocation is 1118. It has a diagnostic significance and also a therapeutic significance, that the presence of 1118 translocation is associated slightly with the lesser responsive to the H. pylori treatment, and they need treatment with radiotherapy or chemoimmunotherapy. So these are the various immunohistochemistry markers which helps to identify the low-grade lymphoproliferative disorders. Of them, the most common are the CD5 and CD23. So CD5 positive neoplasms are CLL and mantle cell lymphoma, and of them, to differentiate CLL and mantle cell lymphoma, we can do a CD23, which is negative in mantle cell and positive in CLL, and cyclin D1 confirms the diagnosis of mantle cell lymphoma. Whereas in marginal zone lymphoma, the expression of the CD5 and CD23 is variable, and most often many markers may be absent in marginal zone lymphoma also. So coming to this is regarding the diagnosis. We take out the lymph node, we do a morphological examination. Based upon this, we do an immunohistochemistry, all express the B cell markers. Apart from that, cell of origin and the identification of the presence of or absence of MYC is important in DLBCL, and identifying the double expressor status and double hit status is very important because they have a prognostic significance, and they also guide us to treat beyond R-CHOP in a case of DLBCL. Apart from the DLBCL, other common B-cell lymphomas are the follicular, mantle, and marginal zone lymphomas, where the follicular is the second most common lymphoma and the most common low-grade lymphoma, where we can diagnose by 1418 translocation and also with the CD10 and BCL2 expression on the IHC. Mantle and marginal zone are slightly less common. We can identify with the 1114 translocation of cyclin D1 and SOX11 expression in mantle cell lymphoma. Marginal zone lymphoma, based upon the site and based upon the morphology, we can diagnose marginal zone lymphoma. If at all needed, we can identify with the help of 1118 translocation. So coming to the classification, how the classification of the lymphomas has evaluated. Classification is the language of medicine, so that there is a uniform pattern of description of the lymphoma, so that the worldwide the incidence and the classification treatment wise there will be uniformity. So this is the need of the classification. So the classifying lymphomas has started way back in 1900s, but that was not that uniform, and everyone has proposed their own mechanisms. And the first organized classification was proposed by Rappaport in 1956. Later, the Lukes and Collins has proposed the classification in 1974, taking into the site of origin and the cell of origin and the state of transformation. They proposed a classification. Later, the Leonard has proposed upgraded the Thiel classification and has proposed the classification into a low grade and high grade. And low grade were called as a lymphocytic lymphomas, and the high grade were called as lymphoblastic lymphomas. So this is the Thiel classification. And later, to avoid the transatlantic differences in the classification between the European and American, a combined classification of real classification, that is the revised European American lymphoma classification, was proposed based upon the cell lineage and differentiation, taking into morphological, immunological, genetic, and clinical information. And later in the 2000s, the WHO came into the picture, and the first international consensus classification of hematological tumors was proposed. Later it was upgraded, and the recent one was the 4th edition, and they have updated the 4th edition in the 2016 and 17, and they take into account the morphology, phenotype, genetic, and molecular features into account while classifying the lymphomas. These are based upon the site, the primary mediastinal, primary CNS lymphoma. The DLB cell has been dissected into multiple types based upon the cell of origin, and based upon the site, and based upon the infectious disease as etiology. I will go through it. And this is the 2017 update of WHO classification, where there is a refinement of the diagnostic criteria, taking into account the morphology, phenotype, clinical criteria, molecular features, that is the various classification exam. For example, previously Burkitt lymphoma was a single entity. Now the Burkitt like lymphoma with 11q aberrations was identified as a separate entity because it is not behaving as a classical Burkitt lymphoma. And infectious disease agents were added into the classification, like EBV positive neoplasms, HHV8 positive neoplasms. So they became a separate entities in the recent WHO classification. And early steps in the lymphoid neoplasms are added. Previously, follicular lymphoma was a single entity, and now the in situ follicular lymphoma and the in situ mantle cell lymphoma were identified as a separate diseases in the recent classification. So this is the in situ follicular lymphoma, and the partial and the in situ mantle cell lymphoma were classified as a separate disease entities in the recent WHO classification. And also association of the infectious disease are also, like the EBV positive LBCL and the extranodal nasal type, and the EBV positive T cell lymphoproliferative disorders of childhood, and HHV positive associated PEL, primary effusion lymphoma, and HHV positive DLB cell were differentiated as a separate entities in the recent WHO classification. So these are the very clinically relevant profiles, the diagnostic criteria to refine the entities, and they have a prognostic and predictive significance. And if at all we identify the molecular profile and the molecular abnormalities, which will help in identifying a target, so that these actionable targets may further improve the outcomes in the lymphomas. So, for example, we know that BRAF and MYD88 has become a signature mutations of the high-risk cell leukemia and Waldenström macroglobulin. So this is in a nutshell what has been updated in the WHO recent classification. The cell of origin has been mandated to identify GCB, ABC based upon we can use IHC and differentiate it. And the EBV positive mucocutaneous ulcer and EBV positive DLB cell has become a not otherwise specified. And Burkitt lymphoma, other subtype like Burkitt lymphoma, like lymphoma with 11q aberrations as a new entity was added. And also the double hit and triple hit status were separated from the traditional DLB cell, and they are designated as high-grade B-cell lymphoma with double hit or triple hit nature. So this is the traditional classification. And in the low-grade lymphomas, the follicular lymphoma was dissected, and the in situ and duodenal type were separated, and the pediatric follicular lymphoma was a new entity. So this is in a nutshell the newer update of the WHO classification. The refinement of the definitions and the diagnostic criteria and terminology was changed, like the in situ follicular and mantle cell lymphoma and GI T cell lymphomas, and pediatric types were separated from the traditional lymphomas. And early in indolent lymphoproliferative disorders like in situ neoplasias and indolent lymphoproliferative disorder of the GI tract were added. And relevance of the phenotypic, genetic, and molecular features were added, like the double hit criteria and triple hit, and the cell of origin like GCB, ABC type of lymphomas. So this is regarding the classification. Thank you.
Thank you so much, sir. So we've received a question on our Q&A. With your permission, shall I read the question, sir?
Yes.
So what is the percentage of non-GCB cases in your practice?
So traditionally, since 3 years, we have been doing based upon the IHC pattern. So what I observe is approximately GCB and ABC account for 50-50%.
So we've received another question. In India, how common followed Hans algorithm percentage of patients get tested accordingly?
So at our institute, we made mandatory to test all DLB cells, cell morphology. Approximately 90% will get tested for the cell of origin.
Thank you, sir.
I think if at all that is not a routine practice, it should be mandated because prognostic wise, also important for the patient to counsel that the ABC subtype of DLB cell, they will not have an as good outcome as a GCB subtype of DLB cell.
So is there any simplified algorithm?
Hans is the most simplified algorithm. There is no more simplified algorithm than Hans.
So if you have any more questions from our panelists, yeah. So thank you so much, sir. We'll move on to our next session. Our next speaker is Dr. Deepak Charles. He will be talking on the topic case presentations, THL. So Dr. Deepak Charles, he's a hematologist from Kochi. Over to you, sir.
Good evening, Ananda. So I'll be presenting a case which exactly does not classify into a double hit or a triple hit lymphoma, but this is something which fared even worse. So the term itself stands for that. So French term for sans espoir, which means we were in a desperate and hopeless situation. So this patient taught us many, so that's why I quoted this. Some people come into your life as blessings, others come into your life as lessons. Coming to his story, he was a 40-year-old male who was settled in UAE. He presented to us in last year during the COVID lockdown phase with a symptom of abdominal pain of 1 month duration. He didn't have any associated B symptoms. There were neither any comorbidities. He was initially evaluated in UAE. I think it was in Sharjah. So where his basic blood investigation seemed normal. Now his imaging with the CT abdomen showed up enlarged, enhancing lymph nodes in the central mesentery and the para-aortic area. The largest node, almost 10 centimeters, which qualifies as a bulky disease. There was minimal free fluid in the pelvis. The liver and spleen was normal. They did a fluid cytology from there. It didn't show any malignant cells. It was only showing cells and tissue cells. They did a laparotomy and an excision biopsy from the intra-abdominal mass, and the biopsy report was consistent with follicular lymphoma, grade 1 to 2, and they described as follicular 80% and 20% as diffuse. Pi 67 was 5 to 10%. And in the immunohistochemistry, the neoplastic cells were positive for CD20, also co-expressing BCL6 and CD10. So confirming a follicular syndrome. With this biopsy report, he presented to us. He did not receive any treatment from the referring hospital. He came to us with severe abdominal pain to an extent that he had to be initiated on opioids. Clinically, he was mildly pale. There was diffuse abdominal mass. There was no clinically palpable nodes, neither was there hepatosplenomegaly. His labs on presentation showed a mild anemia. The total and the differential count as per the counter was normal. The platelet was normal. The peripheral smear showed 12% atypical lymphoid cells. He came to us with a creatinine of 2.9, uric acid of 12, calcium on the lower side and phosphorus on the higher side, with an LDH of 7,000. So with this picture, we were sure that we are not dealing with a follicular lymphoma. And he has presented to us in a spontaneous tumor lysis syndrome. We explored the PET CT, which was showing conglomerate lymph nodes extending from the level of celiac axis till the aortic bifurcation, and the node size has in fact increased in size to 13 centimeters, with an uptake of around 30. There was also splenomegaly, which is not there in the CT done, which is roughly 2 to 3 weeks prior to his presentation here. And there was increased axial and appendicular marrow uptake. Although we didn't clinically feel a lymph node, he had a left axillary node as per the PET CT with a lower uptake. We went ahead with a ultrasound guided lymph node biopsy, and it showed a neoplasm which was composed of a monomorphous population of medium to large lymphoid cells with scanty cytoplasm and round to oval vesicular nuclei, many with distinct nuclei. And the immunohistochemistry was positive with CD20, 10, BCL2, and BCL6. Because of the morphological nature, we wanted to rule out other aggressive neoplasms, especially the mantle and all. So the cyclin D1 was negative, the CMYC was negative, CD30 was negative, and it is not lymphoblastic markers in the AIDS. The Chi67 index was more than 80%, and the biopsy diagnosis which was obtained was diffuse large B-cell lymphoma of a GCB type. Bone marrow, because the smear was showing typical cells, and because moreover in DLB cells we need to do the marrow at this stage. It showed involvement by non-Hodgkin's lymphoma consistent with the DLBCL GCB type. We did a flow cytometry which was showing mature B cell type of neoplasm, CD5 negative and 10 positive. The differentials given in the flow cytometry was Burkitt's, Barrett, DLBCL. However, lymph node morphology was consistent with the DLBCL. We did a FISH, but unfortunately the signals were not analyzable due to high background fluorescence. We also did a bone marrow chromosome analysis, where it showed a neoplastic clone, which is characterized by a balanced translocation involving trans 14 and 18. Along with this, there was a complex karyotype showing multiple numerical and structural abnormalities, deletion 4, monosomy 15, and even deletion 17. So these were the chromosomal changes. You can see the monosomy 15, the deletion 17p, and the chromosomal 14, 18 translocation. So the diagnosis changed from a follicular lymphoma to a high-grade or a DLBCL GCB type, stage 4, bulky abdominal disease with a complex karyotype involving 17p deletion. And according to the risk stratification, it was a high intermediate risk, and he presented as with spontaneous tumor lysis and acute kidney. His CNS IPA was in the intermediate. So he received RCVP as a debulking chemo immediately after the ultrasound guided biopsy, and he was concomitantly managed for tumor lysis syndrome with hydration and urosclerosis. It settled, his creatinine came back to normal within 2 to 3 days, and the settled. In our hospital, our protocol for aggressive behaving B-cell lymphomas is to go ahead with the dose adjusted walk. So 2 weeks after the RCVP, we started him with the Salvage. And he received the first 3 cycles, after which he was clinically improving. His abdominal symptoms fared much better. And we did a PET CT to assess the interim response. Unfortunately, the CT was showing a progression with primary disease in the bulky abdominal site was showing progression and new areas of intra-abdominal lymphadenopathy. However, there was marginal improvement in the spleen as well as the marrow uptake. So considering a primary progression, we changed the regime, we tried salvage him with, and the intent was to go for a transplant. We treated him with RDAP for 2 cycles. After the first cycle, he showed clinical signs of progression with severe unrelenting abdominal pain not responding to opioids. So we had to reduce the bulk of the disease. We tried to give a palliative RT to the abdomen. And we subsequently followed it up with the second cycle of RDAP. After the second cycle, 2 cycles of salvage chemotherapy, PET showed extensive progression with new nodes in the mediastinum, extensive bone involvement, and even almost compressive. So what were the further options we were left with? We conveyed to the patient, he has a primary refractory lymphoma, and there is very few salvageable options at that point of time. We tried to get POLA with chemo. However, there were financial issues. And he was also given an option to go abroad for a clinical trial. And unfortunately, we didn't have the CAR T-cell trial, which is being currently done for DLBCL in at that point of time. He was primed for an allo transplant if at all he attains a remission or even with the disease. And we also advised to him for the palliative treatment. That was considered the last stage because he was too young and he wanted to go aggressive. So with this, he went for a second opinion, and he was given a second cycle of salvage chemo from another center. Unfortunately, his disease progressed, and within 3 weeks, I got a call that this young fellow, unfortunately, succumbed to his illness. So I just wanted to discuss this case to introduce a new term, for me, this was a new term. With this complex karyotype, which was shown in his chromosomal analysis. So there is a good article in Neoplasia published in 2016. We all know that genomic instability is a well-known hallmark of cancer. And there was recent genome studies which have led to the identification of a novel phenomena called as chromocrypsis and chromosynthesis, in which complex genomic rearrangements are thought to be derived from a single catastrophic event rather than by several incremental steps. So in this patient, if you look back, he had a confirmed diagnosis of follicular lymphoma within 3 weeks, and most likely when he presented to us, that could have been transformed to a DLBCL by acquiring new mutations. So he could have harbored the translocation of 1418 at that point of time, which was not checked. When he came to us, he had a complex karyotype, even acquiring 17p. So this term is called as chroma-anengenesis. So, and that is something which has been described, and it tends to complex karyotype, especially at 17p in any lymphoma, tend to be limited, which is overall survival rate less than 20%. And another interesting thing, which when we went back and looked at this, the NCCN latest guidelines show that if you look at the highlighted area down, bone marrow biopsy is not necessary if PET-CT can demonstrate a bone disease. However, in this patient, the aggressive nature of his disease was found out by doing a marrow karyotyping. And so this patient left me with more questions than answers. So we were quite sure that this was a disease evolution, most likely a transformed follicular lymphoma with a new term, which chroma-anengenesis, which is happening. So should marrow karyotyping be done for all clinically aggressive lymphomas? This is one thing which we have been practicing since this patient arrived to us. And there was always a lingering question in my mind: did he receive the ideal chemo? I'm not sure. This was our institute protocol with dosages RPOC. And the question is open, but with regard to the last one, what could have been done better? Thank
you. Thank you so much, sir. If any panelists or attendees have any questions, you can raise your hand.
Yeah, can I ask a question to him?
Yes, ma'am, please go.
Yes, how differently would you have done in the second wave? Would you have omitted anything or anything adding, or how would you have differently managed the case?
With relation to COVID, I would not have changed anything because his disease is too aggressive.
Okay, you would follow the same as it is.
Absolutely.
Okay, sure.
Biju here. Deepak, yeah, I think the case that you presented, it's a truly what you call as refractory. My only question would be, since he had a 17p deletion, would he have considered adding on ibrutinib at the time when after the end of 3 cycles you found a progression? That is the only thing I can think of, something different which we may do now, especially since generic ibrutinib is also available. I'm not sure whether it would have made a difference to the outcome, but whether it would have helped in sort of cyto-reducing the disease, I don't know. But that may have been something, because when somebody is sort of primary refractory to chemo, we need to do something beyond chemo. Otherwise, it doesn't seem to work. And that's our experience also with the patient like you described. Just chemo alone sort of does. And you said the right options of in case of polatuzumab, or if we could go for CAR T cell, this would be the ideal case to go for that.
Yes. Thanks.
So thank you so much, sir. We'll now move on to our next talk. Our next talk is by none other than Dr. Biju George, who's a hematologist from Belur. He'll be talking on the recent advances in newer therapies and relapse non-Hodgkin's lymphoma. So with that, over to you, sir. Sir, can I
Thank
request?
you.
Dr. Biju George, thank you so much for joining us, sir.
Yeah, thank you. Can you see my slides?
I can see your slides, but you put it in slide mode, sir.
One second.
Okay.
I'm just trying to do that.
Okay. That's fine.
So I think the case that Deepak described sort of puts it very well in perspective, because I'm going to talk about what is available. Most of it is not available in India, but it's something that we can look at. So we know that R-CHOP 14 or 21 is the gold standard for DLBCLs. Roughly about 50 to 60% get cured in the long term, but that essentially means that about 40% will not respond to R-CHOP therapy. So once you have a relapsed DLBCL, I think the first question that you look at is this patient transplant eligible or ineligible? If the patient is transplant eligible, both ways you give salvage chemotherapy. If they become PET negative, you would consider an autologous transplant. If they are PET positive, you could consider either an allo or clinical trials. And if they're transplant ineligible, there's a question about whether once they go into remission, whether you would do some salvage. The important thing to remember is that of the people who are transplant eligible and receive salvage chemotherapy, roughly only about 50% would proceed to an autologous transplant. Now, in terms of salvage chemotherapy, I think there's clear data to suggest that whether you use RDAP, whether you use RICE, or whether you use RGDP, there's no difference in terms of the outcome. So any of these chemotherapy regimens you can choose. And once you do that, if you do an autologous transplant, roughly about 50% will be cured. So we need to remember, if you start with 100 patients who need an autologous transplant, only 50 will reach an autologous transplant, and out of the 50, only 50% will be cured with an autologous transplant in the long term. But definitely compared to just giving chemotherapy alone, the PARMA trial showed that autologous transplant is better. EBMT had looked at doing allogenic transplants in diffuse large B-cell lymphoma. Initially, they looked at about 40 to 50% chance of cure, but I think the CABMTR data is a little more accurate and reflective, where they have shown about 20 to 30% chances of cure whether you use non-myeloablative or myeloablative allogenic transplants. With the myeloablative, you had less relapse, but more non-relapse mortality, and with a reduced intensity, you had less NRM and more mortality. So ultimately, we remember that we have reasonable number of patients who are relapse refractory. So what can we do for them? Is there any point in giving chemotherapy? The data, both with using R-GEMOX or BR, is about 20 to 30%, so it's not very useful. There is some recent data on the use of lenalidomide. So this was a study published about 3 years back, looking at lenalidomide alone in refractory DLBCL, 15 to 25 milligrams per day, and overall response rate of about 45%. Importantly, this response was seen mainly in the non-GCB type and not in the GCB. Similarly, in 2019, there was a study looking at ibrutinib at 560 milligram per day plus rituximab plus lenalidomide. It is a small study of 45 patients, but showing a overall response about 44 patients. So this means that there is a small group of patients which may do reasonably well with these drugs, and this is something that is available to us. But there are a lot of drugs or therapies which are not available to us, but which are available around the world. And what are they? And we can divide them into drugs, cell therapy, drug antibody conjugates, and antibodies. So among terms of drugs, the most important would be selinexor. Now, this is an oral selective inhibitor of nuclear export protein. Now, XPO1 is overexpressed in DLBCL, and if you inhibit XPO1, then there is increased accumulation of the tumor suppressors, and that leads to cell death and destruction of the tumor cell. So the SUDDLE trial, which looked at DLBCL who have failed at least 2 to 3 lines of therapy, this is a drug given at 60 milligrams on day 1 and day 3 every week. And they had about 120 patients who had either failed 2 to 3 lines of therapy and about 30% who failed an autologous transplant. And about 70% were refractory to the last treatment that was available. If you look at this data in terms of overall response, roughly about 30% showed an overall response. But importantly here, the GCB subtype showed a better response than the non-GCB subtype. Now, this is different from the other drugs which I've talked about earlier, where the GCP did badly, the non-GCP seemed to do well. So this is something we need to look forward in the future. This was actually approved by the US FDA in 2020 for the treatment of refractory DLBCL. The second is, of course, CAR T-cell therapy. I mean, all of you, I think over the last 5 years, you attend any meeting, you hear about CAR T-cells. This is the process by which you get it. You do a leukapheresis, collect the T-cells, then you induce it using specific constructs. I'll come to that. And then you expand it, then you infuse it back into the patient after some chemotherapy. Now, these are the main focus antigen has been the CD19, and these are the CAR T-cell constructs which have been used in DLBCL. This is what is called as abicaceptagene, tesangilucel. These are the two major ones, Xcarta and Chimera, which have already been approved, and this is the new one. Essentially, the backbone is slightly different in terms of what is the transmembrane domain, and this is the first generation, second and third generation CAR. Now, most of these patients, you generally would give lymphodepletion to help enhance the cytotoxicity of these CAR T cells, and there have been different doses ranging from 2 into 10 to the power of 6 and varying doses which they have looked at. Like I mentioned, the lymphodepletion in the host prior to infusion of the CAR T cells helps in a proliferation of CAR T cells. But the problem with the proliferation of CAR T cells is the cytokine release syndrome, which occurs, which can either be in the first week, second week, or third week. Usually later down the line, it's usually associated with neurotoxicity. And as per US estimates, you spend $500,000 on the CAR T cell production, and you spend $500,000 on the treatment. So obviously, it is quite significant enough to cause a lot of problems. Now, if you look at this, just the summary of all the groups, this is the Zuma and the Juliet is the axisatabine and the tesangilucel. Essentially, there is an overall response of about between 50% to 80%, including 40 to 50% showing remissions. At the end of 6 months after a CAR T cell, only about 30% continued to show the remissions. And then this is data that was published looking at a long-term, a 2-year follow-up, roughly about 30 to 40% continued to remain in remission. So we need to remember that although CAR T cells would show a better response initially, there will be a group of patients that relapse. And so overall, we are looking only at 30-40% of long-term remission with a CAR T cell. Now, people are looking to see whether changing the construct helps, to whether multiple infusions of CAR T cell will be better than a single CAR T cell. And the third, which is going on now, is to look and see whether combining anti-PD-1 blocking antibodies will help in improving the responses. And the early data from the Alexander trial, where you add on pembrolizumab, seems to suggest that it is better in terms of the response. And importantly, it is better in terms of the reduction in the CRS and the neurotoxicity that occurs with CAR T cells. So this is something we need to look for in future. The other exciting group is the antibody conjugates, like you have gemtuzumab and the other inotuzumab. This is a drug called as polatuzumab, which is conjugated to anti-CD22 and which is also attached to this monomethyl auristatin. So those patients, those lymphoma cells which are anti-CD22 and CD19p positive, the antibody binds to it, it gets internalized, then MME gets released, which is a microtubule toxin that leads to apoptosis of cell death. So the initial trial looked at comparing bendamustine plus rituximab versus polatuzumab plus bendamustine rituximab. Initially a total of 6 cycles at 21-day intervals, and essentially showing an improvement in the median progression-free survival and overall survival. Importantly, showing about a 45% overall response as compared to 10 to 15% with just chemotherapy alone. And what was also important was the fact that in both the GCB and non-GCB types, which is essentially the ones in the red lines, they did better than just chemotherapy alone. So it was useful in both of them. Now, it has been so exciting. And so in June 2019, the FDA actually gave approval for the use of polatuzumab. And now people are looking at actually using it along with R-CHOP in untreated DLBCL, and we need to see what the outcomes are with that. There are numerous new monoclonal antibodies. One is Castiximab and Tephacitoma. Castiximab is basically a humanized anti-CD19 monoclonal antibody, and this is given as an infusion every 3 weeks for up to 1 year. They did this study, a phase 1, phase 2 study in patients who had failed at least 2 lines of therapy. And essentially they showed that about 40 to 50% showed response in DLBCL, including 45% in the high-grade DLBCL, which was mainly a complete response. So this is exciting data to look at initially, but we need to see, and the median duration of response for about a year. Safety profile was actually quite good. Only 10% had more than grade 3 adverse events, which included neutropenia and thrombocytopenia. The other important drug is Tephacitoma, which is again a humanized anti-CD19 antibody. But what is important is the FC portion has been engineered to both enhance ADCC and ADCP, and this is combined with lenalidomide to enhance the NK cell function, which would again improve on the tumor kill. So there was this study where they looked at the addition of Tephacitoma with lenalidomide, and they took patients who had failed between 1 to 4 lines of therapy, including 10% who had prior autologous transplant, and roughly about 40% showed a response. 50% showed a response, with about 40% actually showing a complete response. So in 2020, the FDA has actually granted accelerated approval for the use of this combination in refractory DLBCL. Of course, neutropenia, thrombocytopenia, and febrile neutropenia, and its complications of pneumonia were the common complications seen in this group of patients. But this study was important because it seemed to suggest that there was a group of patients who would do reasonably well. And so this was the overall response, and this was with cell of origin. In ASH in EHA 2020, this data was updated. They looked from the primary analysis, now from 17 months, it had gone up to 30 months. The overall response rates continued to be about 58% with a 41% of CR. So, and a median duration of response of 3 years. So it is something which is which you can look forward to, because this may be a good bridging therapy. Like blinatumomab, you have bispecific antibodies, and these are antibodies which bind to both CD20 and CD3. And the most important antibody among all of this is what is called as mosunetuzumab, which is basically a combination of CD20 with CD3. And the second important antibody is glofitamab, which basically consists of 2 CD20s along with 1 CD3. Now, essentially, this BiTE antibody will attach to CD20 on the target tumor cell and will attach through the CD3 onto T cells. This will then lead to transfer of granzyme and perforin to the tumor cell and causes lysis of the tumor cell. This is given as an infusion. There are now data on using it subcutaneous also every week for three weeks in a month. And it was given for roughly about 8 cycles, and this was a phase 1, phase 2 trial. In this trial, they essentially showed that, and important thing was that they had a group of patients who had failed previous CAR T-cell therapy and then went in for the study. Roughly about 30% had a cytokine release syndrome with neurotoxicity about 40%, but majority had only grade 1 cytokine release syndrome. Otherwise, the main thing was neutropenia, fatigue, and hypophosphatemia. It was reasonably useful in refractory B-cell lymphoma, and essentially about 38% showed response with about 20% in long-term remission. And this included about a 50% response in people who had failed previous autologous transplants. And importantly, if you look at patients who had had previous CAR T-cell therapy, roughly about 40% showed a response even to that group of patients. So this is something which is probably useful even in patients beyond CAR T-cell where you want to look at treatment. So if you finally look at the treatment landscape, I think what is important is that just like how the drugs available for myeloma is increasing, I think there's an increased use of other therapies, which includes cellular therapy, which has been approved both in the US and Europe for CAR T-cell, the approval for Tephacitoma with lenalidomide for refractory DLBCL, the approval for polatuzumab, and the fact that there are potentially other bispecific antibodies which are available for treatment which can occur in the future. With this, I'll stop and I'll be happy to take questions.
Yes, Dr. Biju, thank you so much for taking us through the entire landscape. I just want a quick question from you, sir. We know that the CAR T cells have been approved out of the country, and yes, they have access to it. Yeah. Well, how are we managing in India? And what do you do in CMC Vellore when there is an indication for CAR T cells? Okay, so how do you go about?
So the only thing is we ask anybody if they have to do so. Like I said, it's $1 million US. If they can afford it, they can go to the US. I know China, some people have sent them to China for CAR T-cell therapy. Now, I know TMH has started work on CAR T-cells. I think the clinical trials are going on. We are doing some preclinical data on CAR T-cell therapy. So I think there are at least 4 or 5 groups around the country which are trying to develop CAR T-cell therapy. So hopefully in the next 3-4 years, it will be available at a cost which will be at a fraction of the cost of what is available abroad. But that is something we have to look forward to.
Yes, I think. Yeah, so you're right. I think even IIT Chennai is also was trying to collaborate and do something. Okay, but then why it is taking so much of time? So because these type of immunotherapy like dendritic cells and all are already available in India. So why it was a little, I don't know.
You need a lot of investment.
To ask or not.
No, it is because you need a lot of investment.
Okay.
So most of the places where investment is occurring is either that a pharmaceutical company is involved, or you have managed to get a grant from either DBT or one of the others to actually distill you. We are looking at crores of investment to actually first try and prepare CAR T cells, look at the preclinical, and then look at clinical trials before you can even sell it to the public. So
Yes.
that initial investment is what is keeping us back.
Correct. It's not like R&D with the drugs.
No, it is
Yes.
not.
It's not. That's why we are a little behind. But
Yeah.
as technology-wise, we are much ahead of many of the nations. So just a query, because CAR T-cell plays a very important role in many of the cancers, and also coming into some of the solid tumors as well when they relapse and we don't have much options. Yes,
Correct.
Thank you so much. Anybody else want to ask a question? Kashish, we can otherwise move on to the next session.
So I think there was one question about CAR T-cell being done at TMH. Yes, I think what we need to do is to see what is the clinical data, because unless clinical trials are done and initially safety is shown first, followed by efficacy, it is not something that can be shown to the public. So we hope that in the next 24 to 48 months, we would be able to see some clinical data from TMH, which would show that you are likely to get improvement in with CAR T-cell therapy. So question of what is the likely mechanism of spontaneous regression in lymphoma? Now this commonly does not occur with relapse refractory lymphomas. In some of the low-grade lymphomas at the beginning, at the early stages, it can occur, and that is believed to happen because of increased immune surveillance and because of the increase in the pro-apoptotic proteins that can occur within the tumor cell. But this does not usually occur once you have reached a relapse refractory stage.
I may ask you, Dr. Deepak here, sir?
Yeah, Deepak.
So do you find any increased incidence of lymphoma either after the vaccination, COVID vaccination, or the infection? Because there are some reports from around the world with regard to, have you noticed anything like that?
Haven't, but I would qualify it by saying that if you look, see, we have a lot of patient referrals. Now that is sort of actually been cut down by half to 70% because of all the lockdown. So it is difficult to actually estimate whether the amount of lymphomas have gone up. There has always been the question in terms of whether post-vaccination lymphoproliferative disorders will increase. That so far, if I'm not mistaken, we have not seen, and there are no major reports that have shown that.
Hi, it's Rajesh Malik here from Vijayawada. It's not actually a question, sir. Just a thought in terms of some of these multiply refractory non-Hodgkin's lymphoma patients. One other thing which, at least in some clinical trials, has shown some efficacy, and it might be a while before we'll be able to get our hands on, is EZH2 inhibitor tazemetostat.
Okay.
So it's got a different kind of action, and potentially something oral, and given the costs involved with some of these cellular therapies and others, I believe polatuzumab is likely to be available in India this year, and selinexor probably in the near future, and maybe down the line we might probably get tazemetostat as well, but still very early days.
True. I think we need to get more of these drugs in, but I think finally, in terms of its applicability to patients, I think it will all be dependent upon at what cost they come into the market. But this will definitely be important tools that we can use for relapse refractory lymphomas.
Absolutely, absolutely. But none of these, I think will make a huge difference in terms of overall survivals and progression-free survivals. But probably, have like 3 to 6 months of remission potentially. And then you're looking at another line.
Yeah,
and
that
most
is
of
one.
the times it's...
Yeah, but that is one. Second, I would say also, like, for example, the patient that Dr. Deepak had described, this would have been a patient where you could potentially give either CAR T-cell or the combination of polatuzumab, get them into reasonable remission, and then consider either an allogeneic transplant or an autologous if they get a full CR, or at least if you get partial remission, then consider an allogeneic transplant. So I think we have to remember that many of these newer therapies are not an all-in-all cure, but it may be a bridge to doing something more definitive.
Yeah, absolutely right, sir. Yeah. For the non-transplant fit or non-intensive therapy fit, it's just another line of therapy, probably dragging on with a few months of response. Whereas for the young fit and people who can potentially afford any amount of money, I think a bridge to cellular therapy or a bridge to allogeneic transplant. Yeah, right.
So I think there's a question about how is COVID-19 vaccine effective in patients with lymphoma. I mean, there is no data to suggest that it will not be effective. And actually, if you look at the ASH recommendations, they have recommended for the COVID vaccine to be taken for all patients with hematological disorders. The only group where they have actually suggested a deferment is those who have had an allogeneic transplant, and they have said wait for 6 to 12 weeks. Otherwise, in all patients with both malignant and non-malignant indications, and that is what we are doing. We are telling patients to please take the COVID vaccine, irrespective of whether they are actively on chemotherapy or not.
Is that something you've been advising to your aplastic anemia patients as well, sir?
Yes. So aplastics, ITPs, everybody we've been advising to take the COVID vaccine. So far, I mean, the few that we have talked to who have taken, most of them have finished one dose and have not had the second dose. After the first dose, we have not seen any worsening of their blood count so far.
Thank you.
Thank you so much, sir. We'll move on to the last part of the session, which is the panel discussion. Our moderator is none other than Dr. Rajesh Malik, senior hematologist from Vijayawada. So would you like to introduce your panelists?
Yeah. We have an excellent panel of 5 consultants this evening. And Dr. Karunakumar, Dr. Warren Nair, Dr. Subhaya Ramanathan, Dr. Mithun John, and Dr. Sadvik Raghuram. So I'm pretty sure all 5 of them are logged in, and the format I have put forward for this evening is we have about 25-30 minutes or so. So we have 5 excellent panelists. So the topic is maintenance rituximab therapy in non-Hodgkin's lymphoma. So I thought I'd probably give a subtopic for each of our panelists, a few questions for each of them. And each subtopic lasting about 5 minutes. And then in the end, we'll probably have about 5 minutes to wrap up the whole topic and take some questions. So I hope that'll probably work fine. So with that, I will move on to the next, the first subtopic actually. So rituximab maintenance in follicular non-Hodgkin's lymphoma. And I would like to address my questions here to Dr. Karunakumar. So the first question, yes, Dr. Karunakumar here. Hi. So the first question, next slide, please. So do all patients with follicular non-Hodgkin's lymphoma benefit from rituximab maintenance after first-line therapy? Over to you, Dr. Karunakumar.
Yeah. So the question is about rituximab maintenance after first-line treatment, right? So before I answer this question, we need to understand few aspects here. So about the disease per se, we all know that follicular is a lymphoma is a indolent neoplasm, and we treat them only in case of high-grade disease and if they're symptomatic. And even after remission, even we see relapses often in this disease category. So in indolent disease, because most of the patients survive for a longer duration, even with the disease per se. And the second point is the practical aspects here. So when the diagnosis is made and when we see the patient and discuss about the disease, the patient expects an endpoint in the treatment. So he'll ask us, so doctor, how long the treatment is going to be? How long I'm going to come to hospital? Will I be get cured of the disease? These are the very important questions patient will ask to us. So now the point would be the best thing would be to cure the patient. But again, depends on the patient setting and the patient age, comorbidities, and the disease nature of the disease and the chemotherapy regimen which we choose. So usually the practical aspects are, will there be an endpoint in the treatment? The other aspect is how long the maintenance, or if suppose post end of treatment, post 6 cycles, or once the induction is completed. So how long the treatment is going to be? And when we explain about the maintenance in these patients, we have to tell them what the drug is about. So we have to convince them that this is a drug which partially affects your immune system, and it may predispose you to certain risk of infections. Then it's convincing the patient will be a little bit difficult. So these are the practical aspects. And coming to the question per se, usually if you talk about maintenance, I believe that there are two categories of patients where we think of maintenance. The one set of patients are the ones who have achieved complete remission. And the second set are the ones who have achieved partial remission. So if I have to choose personally rituximab maintenance in these patients, I will choose those patients who have partial remission, because logically that would help them prevent progression and at least prevent them from the further aggressive treatment later point. And we know the studies, the benefits and all. But personally, I would choose rituximab maintenance in a patient with a disease of partial response.
Thank you very much. So a couple of slides to back us in terms of where we are with regards to maintenance rituximab in follicular lymphoma and how did we get here. So the major landmark trial is the primer trial, where people were randomized to either maintenance or observation alone after having achieved a CR or a PR, as you have alluded earlier on, and with over 1,000 patients. And there's been a definite benefit with progression-free survival, time to next anti-lymphoma therapy, time to next anti-cancer therapy, but no difference in overall survival. And we now have an update from after nearly 9-year follow-up. And essentially, median PFS is about 10.5 years in the rituximab arm and about 4.1 years in the observation arm. That's significant difference in PFS. An interesting thing is this is independent of age. Sorry, next slide, please. This is independent of age, sex, FLIPI score, induction chemotherapy, CR or CRU or PR. And one interesting thing is about 60% of people who have had rituximab maintenance have still not needed any treatment at 10 years. So as you said, it entirely comes down to, are they in CR or PR? Are they clued in? Are they willing to continue treatment for another 2 years? Are they willing to afford the cost of it with an expense of slightly increased risk of infections for an essentially non-curable illness where we are looking to prolong the PFS, but probably not in terms of overall survival? Right, next slide, please. So this is your second question, Dr. Karan Kumar. A now 64-year-old male diagnosed as having stage 4A, grade 2 follicular non-Hodgkin's lymphoma with FLIPI high score, and who's received 6 cycles of RCVP with a good PR at end of treatment. At that point, he refused or declined maintenance treatment for one of the reasons you mentioned earlier. And 3 years later, he has progressive disease and is now treated with 6 cycles of bendamustine rituximab to a near complete metabolic CR on an end of treatment PET CT. Would you recommend maintenance rituximab treatment post bendamustine rituximab in this second line setting in this patient?
Okay. So here we don't know the reason why the patient declined, and the first therapy received was RCVP, which is not aggressive. Yeah. And the second time he has received proper therapy of BR of 6 cycles, that too near complete metabolic CR. I would keep this patient on observation and follow up, and then once he progresses and symptomatic, then I would think of therapy. I think here I'll postpone my decision of maintenance here at this point. Because he has received BR, effective therapy, I think I would wait here rather than going for maintenance.
Yeah, you're right. I mean, it's not a straightforward yes or a no here. Yeah. So would you have considered maintenance rituximab if he had a PR after bendamustine rituximab in this setting?
Definitely.
As opposed to a near CR? Yeah. Oh, yeah, definitely. Makes sense. And over the next few slides, it's going to show some data to see where we are in terms of maintenance after bendamustine rituximab or maintenance after second-line treatment. There's no prospective trial to show that rituximab maintenance makes a huge difference after bendamustine. In the gallium study, where there was a randomization between rituximab and obinutuzumab in combination with chemotherapy, and maintenance with the same monoclonal antibody that was used at induction, there was definitely increased toxicity in patients who have had bendamustine. But that could potentially have been mainly because of the bendamustine alone rather than due to the monoclonal antibody. And a cross-trial comparison by Rummel, one of the German physicians, suggested that there's definite benefit after bendamustine, similar to that seen in the PRIMA trial, where bendamustine wasn't clearly one of the chemotherapy arms. It was either RCVP or RCHOP or RFCM. So extrapolating that, there was definite evidence of some benefit with post-bendamustine as well. Next line, please. So Hill et al. Have collected some retrospective data from multi-center American institutions. All of them were like fairly big tertiary academic institutions in the US, and collected data from about 640 patients. And this was a retrospective analysis, and they showed there was definite progression-free survival benefit, but that was limited only to the patients who have attained a PR and not to those who have achieved a CR. Next slide, please. And likewise, a meta-analysis of a few studies have shown that the substantial prolongation of PFS and also overall survival in relapse setting after reinduction, as in this particular patient. But none of the trials have actually investigated the role of second-line maintenance in somebody who's had first-line maintenance. So I think it's very difficult to answer the question. And clearly, there's no benefit of considering second-line induction in second-line maintenance in somebody who's had first-line maintenance and probably relapsed fairly soon, like within a couple of years after first-line therapy. And I'm sure everybody will probably agree that there's probably not much benefit for considering second-line maintenance in that setting. Whereas in the patients where they have not had first-line maintenance for whatever reason, maybe if they've had a PR or a CR, even after bendamustine therapy, we probably will consider second-line maintenance therapy. So with that, I guess we'll probably take some questions at the end of the session, unless somebody has anything burning right now. We move on to the second subtopic here. Next slide, please. So this is about rituximab maintenance in mantle cell lymphoma. And our panelist here is Dr. Varun Nair. Dr. Varun, are you here?
Hello. Yes, Dr. Rajesh.
Yeah, hi. Thank you very much. Yeah.
Hi.
So the first question here, Dr. Varun, is, next slide, please. A 61-year-old female with mantle cell lymphoma stage 4B, BP intermediate risk. She received 6 cycles of BR with a metabolic CR at the end of treatment. A fairly straightforward question. Would you give her maintenance rituximab for this lady, and if so, for how long?
Okay, thank you, Dr. Rajesh. So now we have a 61-year-old lady, stage 4 mantle cell lymphoma, MIPI intermediate risk, and she attained a metabolic CR after 6 cycles of BR. So I would prefer observation only, rather than giving the maintenance rituximab. If the induction regimen was used was the RCHOP, then I would have used with much confidence that is to give the maintenance, because till now we do not have the solid data to use the maintenance rituximab even in follicular lymphoma or in mantle cell lymphoma.
Right. Yeah. I mean, I wouldn't say this area is actually a minefield or a very controversial area, but most of the times it comes down to individual preference and I mean, how much of a benefit as opposed to given the cost involved with maintenance rituximab therapy. Toxicity wise, probably not a huge risk, but still, I mean, this is something we shouldn't undertake very lightly. So thank you very much, Dr. Varun. With that, a few slides on where we are with regards to maintenance rituximab in mantle cell. Most studies have shown an improvement in the duration of response, but again, like in the case of follicular, not much in the way of an improvement in overall survival. And a subgroup analysis from Maintain trial by Rummel, it suggested that no additional PFS or an overall survival benefit after BR maintenance, after BR and maintenance rituximab. There's a European MCL study in the elderly population where people who have had maintenance rituximab after R-CHOP chemotherapy have showed a significant improvement in overall survival as well. I mean, especially in people who have had rituximab maintenance as opposed to people who have had interferon maintenance. So interestingly, about 60% of these elderly people who've had rituximab maintenance have not needed any treatment after 4 years of therapy. And in this particular trial, they have given maintenance therapy until disease progression. But that I'm pretty sure is not general consensus in terms of how we would probably consider maintenance rituximab in this particularly elderly group of people. So next slide, please. So a meta-analysis of 3 large RCTs have shown an improvement in PFS, but again, not an improvement in overall survival. And like in the follicular lymphoma, Brian Hill have shown from a large retrospective, multi-center retrospective analysis, they've shown that there is an improvement in overall survival, but only for those patients who have had a PR and not CR after bendamustine rituximab. So with regards to your take in terms of post-bendamustine, I guess there's not a clear yes or a no for maintenance rituximab in mantle cell lymphoma. With that, I'll move on to your next
Dr.
question.
Rajesh, may I interfere? Sorry,
Sure,
may
yes,
I add?
yeah, sure.
Yeah, in mantle cell lymphoma, actually, if the patient is not a transplant candidate, the best option to achieve a prolonged remission is to give induction with R-CHOP followed by the maintenance rituximab. But as you told, actually, the maintenance until progression is not practical in our setup. So usually, what I usually do is to give 2 years of maintenance, extrapolating the data from primary trial.
Yep, that's absolutely true. I think most of us would probably stick to 2 years maintenance as opposed to until progression, because I think it's very difficult to deliver in our setting. You're right, yeah. So the second question I have for you, Dr. Warren, here is a 42-year-old male with stage 4B mantle cell lymphoma may be high risk and treated on the Nordic protocol with 3 cycles of maxi-CHOP alternating with 3 cycles of high-dose RSC to a metabolic CR, followed by consolidation with an autologous stem cell transplant. For this particular patient, would you offer maintenance rituximab, and if so, for how long?
Yeah, sure. So now we have a 42-year-old male, stage 4 mantle, then maybe high risk, and he was treated with intensive induction chemotherapy and underwent the stem cell transplant. So definitely I would give the maintenance rituximab for 2 years, that is every 2 months for 2 years, because we have evidence for that as per the LYSA trial. Yeah, I would go for maintenance rituximab.
Yep, that's right. Yeah, I mean, next slide, please. So the evidence is from the French group data where they had 299 patients. Next slide, please. Who had 4 cycles of RDAP followed by an autologous stem cell transplant. And they randomized about 240 patients into either rituximab maintenance or no maintenance, and had a significant difference in PFS at 4 years, and very marginal, or if at all, no difference in overall survival as with the other trials. But in this particular trial, they've given rituximab maintenance every 2 months for 3 years. And again, there's probably no head-to-head trial to say whether you do maintenance for 2 years or 3 years, and with that extra year of maintenance offer any meaningful difference. So, but I think in our setting where cost constraints and visits to the hospitals do make a big difference in terms of logistics and price, I think it's very reasonable to offer them a monthly maintenance for up to 2 years. Thank you very much, Dr. Warren. Moving on to the next subtopic, and our panelist for this one is Dr. Subaya Ramanathan. Dr. Ramanathan, are you here?
Yes, sir. Yes, sir. Yes, sir.
Sure. So the discussion here is about toxicities and arguments against rituximab maintenance. So with this, I address your first question to you, sir, right?
Yes.
Next slide, please. So next slide, please. So we have a 60, sorry, can you get back,
Previous,
please?
yeah.
Previous one, yeah, sorry. So we have a 63-year-old female with follicular non-Hodgkin's lymphoma, commenced on BR, and 15 days of the first cycle, she was admitted with the pneumonia. And 10 days after cycle 3, was admitted with pyelonephritis. And with a bit of difficulty, she completed 6 BR with reduction in the bendamustine doses, and she only had day 1 as opposed to day 1 and 2 for the 4th, 5th, and 6th cycles. And they achieved a good PR at her treatment and was commenced on maintenance rituximab therapy. But after the first cycle, developed a viral sounding lower respiratory tract infection, followed by secondary bacterial pneumonia. So my question to you here, sir, is would you continue maintenance for this patient? And should she have actually been started on maintenance in the first place, given the history of infections of the first few cycles of bendamustine rituximab? Over to you, sir.
Yes, sir. She is an elderly female, and she has already had 2 major infections requiring hospitalization, one being pneumonia and other pyelonephritis. So in this scenario, I wouldn't continue maintenance, especially after she has got another hospitalization for infection management after the first maintenance itself. And moreover, she more than 60 years, and she has received BR. She has achieved a very good partial response, and especially when I would weigh toxicity before considering maintenance for her.
Yeah, that's correct. I mean, the fact that she had 2 fairly significant infections in the first 3 cycles itself should have, made us think that she probably shouldn't have had maintenance rituximab in the first instance, and probably no point in continuing. The data comes from PRIMA in terms of there was an increase in grade 3 and 4 adverse events, but not any increase in the number of deaths, though there was a slight increase in the number of infections after the rituximab arm, as opposed to the observation alone. And the Maxima trial looked at the safety in about 500 patients across different countries. And there's definite evidence in terms of real-life safety with rituximab maintenance. But this is something that we shouldn't really approach with casualness. Next slide, please. Because there are potentially serious side effects, however rare or uncommon they are. Next slide, please.
So, but in our setup, especially in elderly patients like this, we have to consider costs also. So one episode of febrile neutropenia might cost a lot for management.
Rajesh sir, your mic is muted. Rajesh sir, can you hear us?
Sorry, it looks like I probably muted myself for a minute or so. Sorry, can you get back to the previous slide, please? Yeah. So, a few things with regards to, some of the toxicities associated with rituximab maintenance, hypogammaglobulinemia, which may be more of a problem with CLL rather than non-Hodgkin's lymphoma. And PML is something, however rare it is not something we need to forget. And there have been several reports of PML happening even in the non-malignant setting, like after ITP and autoimmune hemolytic anemia. And one particular thing I've come across as well is delayed and potentially very difficult to treat and unpredictable autoimmune neutropenia after rituximab therapy. So these are some of the toxicities that we should all be wary of and not take maintenance rituximab too lightly. Next slide, please. So this is my second question, Dr. Ramanathan. A 51-year-old male with a 4A follicular non-Hodgkin's lymphoma treated with 6 RCVP to a PR, followed by 2-year maintenance rituximab therapy. And within 12 months after completion of maintenance, he progressed and was treated with 6 cycles of BR to a very good PR. Is this a patient in whom you would consider second-line rituximab maintenance in somebody who is at first-line maintenance and relapsed within 12 years of the first-line maintenance?
He has progressed quite early, within a year, almost in a year. I would discuss with him, and then, though there is no strong data.
Dr. Ramanathan, are you there?
Yeah. Can you hear me, sir? Hello?
Hello. Yeah, I can hear you, sir. Yeah, go ahead.
Yeah. So he has progressed in a year. So after 6 BRs, he has got a very good partial response. And we know from the data that after the relapse setting, the maintenance has got a survival benefit. But in the standard upfront setting only, there is a prolongation in the PFS, not in the OS. So I would consider if you're keen to follow up here, sir.
Yeah, that's absolutely right. And somebody who's relapsed within 2 years of maintenance, I guess, is not likely to do as well given the POD 24 data. But I mean, somebody who's relapsed within 1 year of maintenance, I'm sure most of you would agree that we wouldn't consider second line maintenance for this patient. Thank you, Dr. Ramnan. So next slide, please. So our next panelist is Dr. Mithun John, and I would like to address a few questions about how best to schedule rituximab maintenance. Right, over to you, Dr. Mithun. Are you there, sir?
Yeah, I'm here. So regarding the schedule of rituximab,
Mithun, are you there?
Yeah, I am here. Am I audible? Hello.
Yes, Mithun sir, you're audible.
Yeah.
Dr. Mithun.
So regarding the rituximab maintenance schedule, so if I've decided to give rituximab maintenance, so I would prefer in follicular lymphoma, mantle cell lymphoma, if I've decided to. Hello.
I can see that he is.
Rajesh sir, are you able to hear my audio?
Hello.
Mithun sir, you're audible. I'm not sure why you're not audible to Rajesh sir.
I think there's some internet problems over there. That's
sure.
Correct,
Yeah.
Correct.
Yeah, I got you now. So I can hear you
Yeah.
loud and clear, Dr. Mithun. Yeah, sorry, I don't know what happened there. So my
problem.
first question to you, next slide, please. Next slide, please. Yeah. How do you schedule your maintenance in your follicular and mantle cell lymphoma patients, either in your first line or second line setting?
Yeah, sure. So we have already discussed regarding the pros and cons of receiving rituximab maintenance. And if you decided for maintenance rituximab, I would prefer to give it every 2 monthly. So in follicular lymphoma, what I usually follow is 2 monthly for 2 years. If the patient is willing to come. So they have decided for maintenance therapy. So I would prefer, whether it's in follicular lymphoma, mantle cell lymphoma, to give it at 2 monthly intervals, at least 8 weeks. If the patient is not able to come every 2 monthly, at least 3 monthly.
Yeah, I mean, absolutely right. I mean, most of us would probably do 2 monthly because most of the evidence is from 2 monthly rituximab. But again, there's no head-to-head comparison between 2 months versus 3 months. So I think it all downs to individual preference and logistics. I've seen a few patients have been treated at Vellore. I mean, I'm sure Dr. Viju Jaj might be able to chip in at some point in the question and answer session, because I think I've seen a few of them receiving every 3 months. So I guess it's mostly down to, I mean, individual preference and logistics as opposed to a definite a 2 month or a 3 month regime here. So my next question is, how long, how long do you offer maintenance in follicular non-Hodgkin lymphoma?
Means I usually offer for 2 years. Seeing the prima data also, I think 2-year maintenance is sufficient for follicular non-Hodgkin lymphoma.
Yeah, I'm pretty sure, I mean, everybody would be in agreement with that. And we don't have any evidence from anywhere to say that, I mean, any maintenance beyond that will actually make a meaningful difference. And even with 2-year maintenance, we've seen from Prima that at 10 years, I mean, only about 60% of them have actually not needed any treatment. That's pretty impressive result. So any maintenance beyond 2 years probably is unlikely to make any difference. So my next question is, how long do you offer maintenance in mantle cell lymphoma?
That's going to be a tricky question, actually. Yes. So in mantle cell lymphoma, usually we tell that to give it, if you are giving R-CHOP or RCVP, to give it beyond progression, up to progression. So until progression is going to be a bit difficult. So when I explain the patients, most of the patients won't be allowing to go for infinite duration of treatment. So I usually give it for around 2 years, maximum 3 years, not more than that.
Yeah, that's exactly, yeah. So the data is from one of the elderly German trials continued until progression, which, as you and the speakers earlier have alluded to, is very difficult to do in our setting. And 3 years, I mean, the data is from the French group post autologous stem cell transplant. So I guess most of us would agree that we'll probably continue maintenance for 2 to 3 years for most of our mantle cell lymphoma patients, but probably not indefinitely. And so there's no head-to-head comparison for any of these in terms of whether you do 2 monthly as opposed to 3 monthly, whether do 2 years versus 3 years, or whether do 2 years versus until progression. So that was, sorry, short and sweet. Thank you very much, Dr. Midun there. And I would move on to the last topic here. And our panelist for this one is Dr. Sadvik Raghuram. Next slide, please. Dr. Raghuram, are you there?
Yes, sir, I'm here.
Yeah, thank you very much. Yeah. So this is, I mean, I think we're probably dealing with a slightly premature or an imaginary scenario here, but I guess it won't be long before we probably will get subcutaneous rituximab in India as well. So I'm going to start off with an imaginary scenario where, let's say, we do have subcutaneous rituximab available in India. So next slide, please. So this is a 73-year-old lady with 4A follicular non-Hodgkin's lymphoma treated with BR to a good response, and is on maintenance rituximab and has completed 4 infusions so far. But given the current pandemic scenario, she calls up and says, if there's any chance, given that subcutaneous rituximab is available, would getting it at home would be an option. So this is an imaginary scenario, assuming we do have subcutaneous rituximab and we have a trained nurse who's able to go to the patient's home and deliver it at home. So what are your thoughts, sir?
Yeah, so he's a 73-year-old female who's achieved CR to rituximab and bendamustine. So presuming that the patient wants to continue with maintenance rituximab and not stopping it, subcutaneous rituximab has a good data, and it can be offered to the patient. The thing is, it is not only the efficacy wise, but even the adverse event profile is more or less similar with IV rituximab, except the local injection site reactions. Otherwise, the neutropenia and all those things are more or less similar. And there were like other few studies also done, which suggested that because of the ease of administration at the time, the patient preference was more for the subcutaneous formulation rather than IV formulation. So considering the COVID situation and presuming the patient wants to continue rituximab, I would definitely ask her to continue with subcutaneous rituximab.
Dr. Rajesh? Sir, are you there? So I think Dr. Rajesh is facing network issues. Can I request, or if the panelists have any questions for our speakers, or if the audience have any questions for our panelists, you can please put it in the Q&A box or the chat box, and till Rajesh sir comes back, we can probably take those questions.
This is Biju here. So I think Rajesh was just asking about our practice. We use only once in 3 months. That is more in terms of logistical issues. But, and I was just trying to pull out, there is one publication in 2015 where they looked at the patients in the PAMA trial who had either 2 months or 3 months and showed that the toxicity in those who had every 2 months was higher than those who had every 3 months.
So I just got to the last bit, Dr. George. Thank you very much for chipping in. I don't know what happened there again, and I seem to have disappeared off the radar and then back again now. So thank you. I mean, so so most of your patients at Vellore would probably be on 3 monthly maintenance.
Correct.
Is that correct, sir?
That's correct.
Okay.
That's correct.
Yeah. Okay. Yeah. Makes sense. Makes sense. Yeah. So sorry. Before I disappeared earlier, the data from Spark, Sabrina, and Sawyer have initially shown non-inferiority of subcutaneous rituximab compared to the intravenous rituximab. Next slide, please. So with that non-inferiority evidence, I think subcutaneous rituximab has been approved both in Europe as well as in the US. Initially for non-Hodgkin lymphoma, and then for CLL in Europe, and then simultaneously in the US. And a fixed dose of 1400 milligrams is used in follicular lymphoma and DLBCL. Whereas for the CLL patients, where they get 500 milligram per square meter from second cycle onwards, there's a 1600 milligram subcutaneous version available. So the subcutaneous solution had to be concentrated by 12-fold. So that means, I think it's a very concentrated solution, and then the absorption may not be that great. So what they've done is they've added in recombinant hyaluronidase to the rituximab to facilitate better distribution and absorption. So there's two fixed dose versions available, 1400 milligram, which is used in non-Hodgkin lymphoma, and 1600 in CLL. Next slide, please. So there's some analysis done more or less like post-marketing or post-use, and in terms of cost and benefit and all of that, coming from the Canadian SCUBA study, and then MAVIS, and then PRIFMAV, which was like a patient reference questionnaires. And all of them have confirmed that there's significantly less preparation time and much significantly less administration time. So the subcutaneous is administered over 5 minutes, whereas as we know, the intravenous version can take anything, even from a rapid infusion from about 90 minutes to 3 to 4 hours intravenously. And because of a fixed dose combination, there's less wastage, and much less in the way of infusion reactions. Though even though patients do get subcutaneous rituximab, they invariably get the first dose as an intravenous infusion, and only from the second dose onwards they get it subcutaneously. And as we have noted from these trials, that there's much better patient satisfaction given much less time spent in the hospital. So the France and Canadian data have suggested that significant cost savings, but I think coming to the Indian setting, that may not really be possible, because most of the rituximab that we use are actually generics. And when we lay our hands on the subcutaneous version from Roche, it would still be in patent. And unless they price it very, very competitively, I guess the pricing will be high. And we'll certainly be looking at how much of a difference does it make in terms of cost-benefit analysis. Because, certainly when I moved back from the UK to India, most of the patients there were getting subcutaneous rituximab from cycle number 2 onwards. But when I was recently chatting to some of my colleagues in Scotland, they were saying that they've now moved back to doing intravenous rituximab, because the benefit of savings with regards to generic rituximab IV as opposed to using subcutaneous rituximab was so much that they thought, moving away back to intravenous rituximab meant a lot of cost saving to the National Health Service. So when it is launched in India, we need to look to see how competitively priced it is. And there may certainly be an outpatient who would probably be willing to afford, however, the price is. But otherwise, I think we'll probably be looking at how much with regards to saving the chair time and how much expensive it is before we'll probably roll on to the general population. So with that, I think I've completed pretty much on time. So probably have a couple of minutes for questions and answers. And maybe some of them have already been answered. So there's a question here. Yes, yeah.
Dr. Tarun Kumar, I have a question.
Yeah, sure. Go ahead, sir.
This question is to Dr. Biju, sir.
Yeah.
Is sir in the group, available in the group?
Yeah. Tell me.
Sir, I have few questions, sir. Sir, from your experience, sir, personal experience, who is the ideal patient for rituximab maintenance, sir, in your practice in follicular lymphoma?
So for us in follicular lymphoma, we would definitely give for everybody, not just the people in CR, but not just the people who have got PR, but even for those in CR, on the understanding that although it doesn't make a difference to the overall survival, the progression-free survival and the time to next treatment is definitely delayed. So all patients with follicular lymphoma, we would give maintenance rituximab.
Irrespective of age, sir?
Irrespective of age.
Okay. So second question, sir. So you told us about vaccine. You are advising patients to get vaccinated, especially lymphoma. In relation to rituximab, sir, usually we avoid it 3 to 6 months. So is there any change in your practice or the vaccination?
No. So vaccination, even for those with lymphoma on rituximab, we are advising vaccination. Now, if you ask me whether with the B cell depletion, you'll get adequate neutralizing antibodies, I don't think the data is there. But the risk of severe COVID outweighs, I think, the benefit that the risk of severe COVID is very high, which is mitigated by vaccination. So that is why you would rather give the vaccination. And if you look at the ASH recommendations, their recommendations are to give vaccination. So I'm advising for everybody.
Irrespective of time period.
That's what I've been doing as well, sir. I tell them that it's less likely to be effective, but probably the toxicity is not going to be any more compared to a normal person, but may not be that effective given the fact that they may have had rituximab recently. But I think given the current scenario, waiting for 6 months is probably going to put them at a significant risk of a severe COVID infection as opposed to maybe the vaccine not working.
Correct. Absolutely. I think it's just a question of risk versus benefit. And the risk with COVID is probably much higher than the fact that the vaccine may not work.
Sir, is there any study or evidence to just, so with COVID, we definitely don't have, but the response, immune response to the vaccine. So is there any data?
So if you look at the data from transplant, even patients with chronic GVHD, where we know that the immune reconstitution is slow or obtunded because of therapy, they still would advise going ahead with your primary immunization, except for the live vaccines. So it is extrapolation from that data. I don't think there's clear data specifically, because this is the first time that we are facing the scenario. And that is why I said our recommendation for going at vaccination also is not truly based upon specific data. But we are just going by the data which is there in transplant, which seems to suggest that giving vaccine will not have a problem. And anyway, for us, all these patients, not for the COVID, but the others, we are looking at vaccine reconstitution. What we hope down the line to do is, in those who have had a vaccine, we could subsequently look to see what has happened in terms of development of antibodies.
Thank you, sir.
So
and some of the vaccines may have, sorry, go ahead.
Yeah, just wanted to ask, any difference whether it's an mRNA vaccine or a viral vector vaccine, that is the inactivated, what we are using like Covaxin? Will the immune response differ as far as these cases are concerned? I know all of my patients, I advise vaccination, except until and unless they are on a transplant or they are getting a high dose chemo like AML inductions. So like any difference, any thought process?
See, if you look at vaccine conversion, yes, there's a difference between those which are mRNA vaccines versus the other vaccines. But I would say there is not enough data in patients who are immunocompromised. So I would just go ahead with whatever vaccines are available right now. I think the earlier they get to it is better. But I would also say that we need to look down the line to see whether they have got enough antibodies. And there is now a question about whether you should actually give a booster dose. that is something we need to look at in patients who are immunocompromised, like our lymphomas, who are on rituximab therapy.
Yeah, I also agree with you, sir, but with the new vaccination guidelines, which say that 12 weeks after the first dose, maybe there is some modification with an immunocompromise, whether the second dose can be preponed a little earlier. That's what I think. The fourth point in the guideline says that, okay, the new revised vaccination guidelines in India says that prepone the second dose if you are immunocompromised.
So one of the things we need to remember is some of the guidelines are more practical and pragmatic rather than it being scientifically based. And that, I think, part of it has got to do with the fact that if everybody decided to take the second vaccine within a month's time, there is not enough vaccines to go around for some people to even get their first vaccine.
Correct.
So I think based upon data from outside, it's reasonable to suggest that instead of the 4-week gap, you could push it to 6, 8. Some are even suggesting 12 weeks for normal people. But I would not push that much for somebody who's immunocompromised.
Yes, right.
I think quite a lot of this is down to the logistics, and the government advisory keeps changing in sync with the demand and the supply. Because if you look at the CDC guidance for people who have had an active COVID infection and when to take the vaccine, I mean, most of the recommendations are like you should probably take it within 2 weeks or so. But now the new latest government advisory is that you put the vaccine back by 3 months after COVID infection. So I guess it's all down to the logistics of how much vaccine is available and the fact that you've recovered from a COVID vaccine. You could probably take a step back and get somebody else get the first dose as opposed to somebody who's recovered from a COVID. It's probably my take on that.
Yeah, correct. Absolutely.
I have a question with regard to marginal zone lymphoma. So most of the treatment guidelines are in lines with the follicular lymphoma. So would you advise maintenance therapy in these patients, especially when there is
we give it. I mean, I don't think there are randomized trials to look and say there is a benefit, but we follow like a low-grade lymphoma, like follicular lymphoma, we would definitely give maintenance for 2 years.
So that's something probably I would as well, follicular and mantle cell. I mean, but I mean, I wouldn't say unfortunately, but I mean, most of our patients are actually in the government schemes, and we do not have maintenance rituximab covered under the government schemes. So for that reason, we're not able to do it. But otherwise, yeah, I mean, for most of the patients, irrespective of whether they're transplant eligible or non-transplant eligible. Yeah.
Sir, since you brought discussion for the government scheme, what about using just lenalidomide maintenance in a government when you don't get, like I also work in the government sector, medical college. So a thought process of having lenalidomide in case you're not able to get the rituximab.
Well, I mean, there's not much data in terms of lenalidomide maintenance in low-grade lymphomas or mantle cell lymphoma or any of the lymphoproliferative disease for that matter. I mean, apart from in the relapse refractory setting where if somebody is responding to lenalidomide, you keep going until they progress or until they develop adverse events, as opposed to maintenance in myeloma. So, I mean, from a cost perspective, probably, yeah, much more deliverable. But then again, I don't think there is data to say that we can consider lenalidomide maintenance in the lymphoproliferative disease setting.
And I think if no further question, Kashish, any other questions are there, or we can conclude today?
Ma'am, we can conclude.
Yeah. Yes, thanks to again everybody, both the foundation, Kavina Creation and CIPLA for bringing all of us together. We had real practical discussion on how to go about and how to manage little differently. As you know, the second wave is completely different. So many questions, discussion, and how to go about with the immunotherapy, vaccination, standard of care. And we had very good cases being discussed, and we learned from all the experts in the field. And I think Southern India, better to call it. And then that's all. Good night. Thanks. Stay safe. Stay connected. We'll again meet on a different forum. Thank you all so much. Thank you so much.